Hi, this is Dr. Akhtar Amin, and today our topic is anatomy of the eyelids, and we will discuss a quick review of the anatomy of the eyelids. So, first talk about the palpebral fissure. It is the exposed ocular surface between the upper and lower eyelids. Normally, in the adult, the palpebral fissure is 27 to 30 millimeter and in long, and 8 to 11 millimeter wide. 8 to 11 millimeter wide. The upper lid, it is more mobile than the lower. The upper lid can be raised 15 millimeter by the action of levator palpebrae superioris muscle alone, and it can be raised another 1 to 2 millimeter by the action of the mular muscle. Now, if the frontalis muscle of the brow is used, the palpebral fissure can be widened an additional 2 millimeter. Now, anatomy. Although this is a small area, the eyelid, but it is complex in structure and function. When the anatomy of the upper eyelid is described, it is helpful to divide it into distinct segments from the dermal surface inward. So these segments include the following structures. Number one is skin and subcutaneous tissue. This is skin and subcutaneous tissue. And second is muscles of protraction. The muscles of protraction are orbicularis oculi muscle. This is orbicularis muscle, and this is the main protractor. Third one is orbital septum. This is the orbital septum. Fourth one, these are the muscles of retraction, and they include levator. This is levator palpebrae superioris muscle, and mular muscle. This is mular muscle. Here you can see beneath the levator, this is mular muscle. And capsulopalpebral fascia. This is capsulopalpebral fascia, and inferior tarsal muscle, and here is inferior tarsal muscle. This is inferior tarsal muscle. Fifth one is orbital fat. Here you can see the orbital fat. Sixth one is tarsus. Here you can see tarsus. This is tarsus. Tarsal plate. This is tarsal plate, which contain meibomian glands. In the seventh, the most on the inner side is conjunctiva. This is conjunctiva. Palpebral and bulbar. Palpebral and bulbar conjunctiva. Now let's talk each segment of the eyelid one by one in detail. The first one is eyelid skin. This is the eyelid skin, and the subcutaneous connective tissue. This is the subcutaneous connective tissue. The eyelid skin is the thinnest in the body. It contains fine hairs, you can see, sebaceous glands and sweat glands. Here is the superior eyelid crease. This superior eyelid crease is present near the upper border of the tarsus. Here, this is the upper border of the tarsus. At the upper border of the tarsus, the levator epineurosis. This is the levator epineurosis. It established the first insertional attachments. In many individuals of Asian descent, there are few attachments of this levator epineurosis to the skin near the upper tarsal border, and the superior eyelid crease is minimal or absent. Here are two racial variations in eyelid anatomy. These are two major racial variations in the eyelid anatomy. In this one, the orbital septum, this is the orbital septum. It inserts onto the levator epineurosis above the tarsus. Above the tarsus. In variant 2, here on the right, the orbital septum inserts. This is the orbital septum. This is the orbital septum. It inserts into the levator muscle, levator epineurosis, and this is levator aponeurosis. So the septum inserts onto the levator aponeurosis between the eyelid margin and the superior border of the tarsus. This is superior border of the tarsus, this is eyelid margin. So it insert here, and in this case there are fewer attachments to the skin and there is no crease. In this case here are a lot of attachment to the skin, so here a crease is formed at the superior border of the tarsal plate. The loose connective tissue of the eyelid contains no fat, no blood or other fluids. So it contains no fat, so blood or other fluids can accumulate beneath the skin, and this blood or other fluids can cause rapid and dramatic swelling of the eyelids. The eyelid margin, this is the eyelid margin. It contains several important landmarks. A small opening, here you can see the punctum of the canaliculus. This is punctum and here it is canaliculus inside the eyelid margin. It is present medially at the summit of each lacrimal papillae. The superior punctum, which is not visible in this picture, it is normally hidden by the slight internal rotation. Superior punctum is located more medially than the inferior punctum, and the superior punctum is usually opposed to the globe and not normally visible without eversion. Another important thing is the gray line. Here you can see the gray line. What is this gray line? This along the entire length of the free margin of the eyelid is this delicate line, and it corresponds histologically to the most superficial portion of the orbicularis oculi muscle, the muscle of Riolan, R-I-O-L-A-N, Riolan, and to the avascular plane of the eyelid. Anterior to this line, you can see the eyelashes or cilia oris. Behind this line, you can see the openings of the meibomian, also known as tarsal glands, just anterior to the mucocutaneous junction. The eyelashes are arranged in 2 or 3 irregular rows along the anterior dermal edge of the eyelid margin. The eyelashes are usually longer and more numerous on the upper eyelid than on the lower one. The margin contains also the glands of Zeiss. The glands of Zeiss are modified sebaceous glands, and the glands of Zeiss are associated with the cilia. Also there are glands of Moll. The glands of Moll are apocrine sweat glands in the skin. Here you can see the glands of Zeiss associated with lash follicle, and here you can see the gland of Moll. So these are the glands, and they are in the margins of the eyelid. Here you can see again the gray line, the meibomian gland orifices, and here you can see the muscle of Riolan. The gray line is actually the muscle of Riolan. Below the eyelid is the muscle of protraction, also known as orbicularis oculi muscle. This is orbicularis oculi muscle. The orbicularis oculi muscle, it is the main protractor of the eyelid. It is arranged in several concentric bands around the palpebral fissure. It is divided into orbital, this is the orbital, and palpebral parts. Orbital parts, this is the orbital part. It occurs along the orbital margin, and the palpebral parts. The palpebral parts has divided into further 2 parts: preseptal, attached to the septum, and pretarsal, attached to the tarsus or tarsal plate. Innervation occurs by cranial nerve 7, the facial nerve. The orbital part, this is the orbital part. It inserts in a complex way into the medial canthal tendon and into other portions of the orbital margin and into the corrugator supercilii muscle. The orbital part, this is the corrugator supercilii muscle to which the orbital part attaches. The orbital portion of the orbicularis muscle. The orbital part of the muscle, it acts as sphincter and function solely during voluntary closure of the eyelid. So it causes closing of the eyelid, voluntary closing. The second part is the palpebral. This is palpebral. Palpebral orbicularis oculi muscle function both voluntarily and involuntarily. Involuntarily during spontaneous and reflex blinking. It consists of preceptal and pretarsal portions. Both unite along the superior palpebral furrow. The pretarsal orbicularis muscle adheres firmly to the tarsus. This is pretarsal. A portion of the pretarsal attaches to the anterior lacrimal crest and the posterior lacrimal crest. This portion is called Horner muscle. Horner muscle is a portion of this muscle. It is attached to the anterior lacrimal crest and posterior lacrimal crest. This muscle plays a role in the tear drainage. Orbicularis fibers extend to the eyelid margin, where there is a small bundle of striated muscle fibers called the muscles of Rivulin, which you already have seen. This is the muscle of Rivulin. Here you can see the pretarsal is attached to the tarsus. Here below is the tarsus. Here you can see the Horner muscle. The Horner muscle, it is the portion of the pretarsal muscle. It is attached to the anterior lacrimal crest and the posterior lacrimal crest. This play a role in the tear drainage. This is the muscle of Rivulin. These are the orbicularis oculi muscle fibers which extend to the eyelid margin, where there is a small bundle of striated muscle. Next, very important, is orbital septum. It is a thin sheet of connective tissue. It encircles the orbit as an extension of the periosteum of the roof. This is roof and the floor of the orbit. Superiorly, you can see the septum is attached firmly to the periosteum of the superior half of the orbit margin. At the arcus marginalis. This is arcus marginalis. So this is the septum. It then passes medially in front of the trochlea and continue along the medial margin of the orbit, along the margin of the frontal process of the maxilla and onto the inferior margin of the orbit. Centrally, the orbit septum is attached to the epineurosis of upper and lower eyelid. This is epineurosis, and here it is the attachment. Now this septum delimits the anterior or posterior spread of the edema, inflammation, or blood. The clinical examples include preseptal cellulitis. Anterior to this, there will be preseptal cellulitis. If it goes posterior to this, then it will become the orbital cellulitis. And it also limits retrobulbar hemorrhage. Now, if we cut the orbital septum, what will be posterior? Posterior, there will be orbital fat pads. Orbital fat pads, also known as pre-aponeurotic fat pads, behind the superior septum, behind the inferior septum. And here you can see the lacrimal gland. So there is a clinical pearl. If you come across a patient with periorbital laceration and there was the presence of orbital fat, what will it indicate? It indicates the violation of the orbital septum. Now the muscles of retraction. These are very important muscles. The levator palpebrae superioris muscle, this is levator palpebrae superioris muscle, and the mular muscle. Now the levator palpebrae superioris muscle, it is very important because it is the main retractor of the upper eyelid, and it causes 15 millimeter retraction and elevation of the upper eyelid, and it originates from the lesser wing of the sphenoid bone, and the body of the levator muscle overlies the superior rectus muscle. This is superior rectus muscle, and then travel levator muscle travel anteriorly toward the eyelid. The muscle is 40 millimeter long, and the muscle is innervated by the superior division of cranial nerve 3. Here again you can see levator. This is levator palpebrae superioris muscle. Note the transition into the aponeurosis at the ventral ligament. This is ventral ligament. Also you can see here, this is ventral ligament, and the aponeurosis passing through the pretarsal. This is pretarsal orbicularis muscle to the eye skin, to the eyelid skin. This is the eyelid skin. So the aponeurosis goes towards the skin. Here again you can see the levator palpebrae superioris muscle, and here you can see the ventral ligament, also known as superior transverse ligament. This ventral ligament is formed by condensation of tissue surrounding the levator muscle, and this ventral ligament, it provides support for the upper eyelid and surrounding tissues. Now at this point, at the point of ventral ligament, the levator muscle transitions into aponeurosis anteriorly. This is aponeurosis, and posteriorly it is attached to the mular muscle, also known as superior tarsal muscle. Another point is at this ventral ligament, the levator muscle posterior vector, the levator muscle anterior posterior vector changes to superior inferior vector towards the aponeurosis. Now this is levator aponeurosis, and it is actually the tendon of the levator muscle. It is 14 to 20 millimeter in length and has many attachments to the eyelid and surrounding orbit. One of the attachment of levator aponeurosis, which is the tendon of the levator muscle, is through the orbicularis oculi muscle and inserts subcutaneously here to produce superior eyelid crease. This is superior eyelid crease. Here you can see this is the superior eyelid crease, and these are the aponeurosis of the levator muscle. This is levator aponeurosis. Posteriorly, the levator aponeurosis insert onto the surface of the tarsus. Here you can see a tarsus and the attachment of the levator aponeurosis. The aponeurosis forms its firmest attachment onto the anterior surface of the tarsus, approximately 3 mm superior to the eyelid margin. 3 mm superiorly, here it is the strong attachment. The aponeurosis also inserts into the trochlea of the superior oblique muscle, and into a fibrous tissue bridging the supraorbital foramen or supraorbital notch. The lateral horn of the aponeurosis, it divides the lacrimal gland into orbital and palpebral lobes and insert at the lateral orbital tubercle. The medial horn, this is the medial horn, it insert at the posterior lacrimal crest. Aponeurotic attachment also exists with the conjunctiva of the upper fornix and the orbital septum. So the first muscle was levator palpebrae superioris, and the second retractor muscle is the mular muscle. It is the mular, here is the mular muscle. This mular muscle, also known as superior tarsal muscle, it originates from the under surface of the levator palpebrae superioris muscle in the upper eyelid. Here you can see its origin. Now this mular muscle, this is a smooth muscle, and it is innervated by the sympathetic nervous system The action of mullar muscle is responsible for 1 to 2 mm of the upper eyelid lift. The mullar muscle attaches to the upper border of the tarsus. Here you can see upper border of the tarsus. And into the conjunctiva of the upper fornix. Here you can see the conjunctiva of the upper fornix. So these were the muscles of retraction of the upper eyelid. Now we will discuss the muscles of retraction of the lower eyelid. So now the muscles of retraction in the lower eyelid, the retractors are the capsulopalpebral fascia. This capsulopalpebral fascia, you can see it is analogous to the levator aponeurosis in the upper eyelid. In the retractors is the inferior tarsal muscle. Inferior tarsal muscle arises from the capsulopalpebral head of the inferior rectus muscle in the lower eyelid. Like the mullar muscle, the inferior tarsal muscle is the smooth muscle, but it is much weaker, and it attaches to the lower border of the lower tarsus. Now the lock-cord ligament. It is the inferior equivalent to the Whitnell ligament. Above is the Whitnell ligament, below is the lock-cord ligament. It is a suspensory ligament of lock-cord. It is a fusion of the sheet of the inferior rectus muscle and the inferior tarsal muscle, and a check ligament for the medial and lateral rectus muscles. This ligament provides support for the globe and the anterior-inferior orbit. And this lock-cord ligament is very important because it is important in surgery and operation on the inferior rectus. It is associated with palpebral pressure changes. Now, tarsal plate or tarsus. It is a dense connective tissue and it is not cartilage. And the tarsus are attached to the orbital margin by medial and lateral canthal tendon. And although the upper and lower tarsal plate are similar in width, the width is similar, 29 mm, and the thickness is 1 mm. But the height of the upper and lower eyelid is different. The height of the upper tarsus is 11 mm, while the height of the lower tarsus is 4 mm. Now the meibomian glands, tarsal glands, modified holocrine sebaceous glands, oriented vertically in parallel rows through the tarsus. Their distribution and number within the eyelids can be observed by infrared imaging of the eyelid. Here you can see infrared imaging of the eyelid. A single row of 30 to 40 meibomian orifices is present in the upper eyelid, but there are only 20 to 30 orifices in the lower eyelid. Ile or meibum from the meibomian orifice forms a reservoir on the skin of the eyelid margin and spread onto the tear film with each blink. Alteration in meibomian gland lipid composition and secretion play a role in dry eye. Aging is associated with an alteration in the lipid profile of the meibum and with meibomian glands. Now the conjunctiva. The conjunctiva, there is palpebral conjunctiva, also known as tarsal conjunctiva. This is palpebral conjunctiva. It is a vascularized transparent membrane consisting of non-keratinized stratified squamous epithelium that lines the inner surface of the eyelid. It is continuous with the conjunctival fornices called cul-de-sacs. It merges with the bulbar portion. Here it is the bulbar conjunctiva, covering the anterior portion of the sclera before termination at here at the limbus. The conjunctiva is discussed further in later chapters. Thank you very much for your time, and please subscribe.